I have the pleasure of introducing Dr. Gluckman. So Dr. Gluckman is the medical director of the Center for Cardiovascular Analytics Research and Data Science at the Providence Heart Institute in Portland, Oregon, as well as being an adjunct faculty member of the Shikharoni Center for Prevention of Heart Disease at the Johns Hopkins Hospital in Baltimore, Maryland. His principal clinical interests include identifying, coordinating, and implementing cardiovascular care improvement strategies. He's authored and co-authored over 100 scientific articles, reviews, and book chapters. His work's been published everywhere, so Journal of American College of Cardiology, CIRC, Circulation Cardiology, Quality and Outcomes, JAMA Cardiology, Journal of American Heart Association, and of course New England Journal of Medicine. He previously served as associate editor for the guidelines and clinical documents for ACC.org, which is the primary website for the American College of Cardiology, and the chair of ACC's Solution Set Oversight Committee, overseeing the policy and clinical documents that are issued by the ACC. He's immediate past governor for the Oregon chapter of the ACC, and he's a board member of the American Society for Preventative Cardiology. He previously served as national chair of the ACC's Patient Navigator program focus on MIs and the ACC's Quality Summit. He's a member of the Operations Committee of the American Heart Association, Outcomes Research, and a site member of HA's Target for the Aortic Stenosis Initiative. Finally, he's the lead developer of one of the apps that a lot of us use all the time, which is the ASCVD Risk Estimator app. And he's here to talk to us about something that none of us ever see, right? Atrial fibrillation, some of the unmet needs, and some of the promising advances. Thank you.
Thank you so much for the kind introduction. And it's a pleasure to be back with you. I was just stating before the break how impressed I am by all of you, and kudos to all the meeting organizers and Dr. Khan. Dr. Khan, thank you for the kind introduction and the invite to be here. I'm hopefully not going to stand in anybody's way, but I wanted to highlight atrial fibrillation. My job was made a little bit easier by the fact that new guidelines came out just about 3.5 months ago, national guidelines. So I'm going to be highlighting a lot of that here today. Disclosures are listed here. And learning objectives are listed here. And I'm not going to systematically read through this, but I do want to focus in on the role that we all collectively play in the population with atrial fibrillation. And I'll get into this in a moment as it relates to stroke and systemic embolism risk assessment. And then in addition to that, how do we modify modifiable risk factors? And then ultimately, is there a role for, beyond controlling one's rate in those who need it, a so-called rhythm control strategy? It's a rhetorical question. The answer, of course, is yes, but we'll get more to that. So a little bit of an introduction. What is atrial fibrillation? And I know this is at the most basic level, but I will highlight the fact that it is the most common sustained arrhythmia, not only in the United States, but worldwide. It is growing in prevalence, as I will show you in a moment. And as is pictorially illustrated at the bottom, the abnormalities that underlie atrial fibrillation, its genesis, in most cases, originate from the muscular sleeves on the back or the posterior wall of the left atrium, those that encircle the origins of the pulmonary veins. So why do we care about atrial fibrillation? Beyond the fact that we probably all personally know someone who has atrial fibrillation, we certainly care for people with atrial fibrillation. It's associated with a lot of not so good things for the patients who are unfortunately diagnosed with it. Substantial increased risk of stroke, and in contrast to other types of stroke, more likely that people will be left with major deficits, increased likelihood of being bedridden, and then ultimately an increased risk of death. There's a heightened risk of dementia. This is unequivocally felt to be related to multi-infarct dementia and a predisposition to dementia that way. Heart failure, myocardial infarction, venous thromboembolism, and then mortality in and of itself. And I do think it's important to talk about how we classify atrial fibrillation. I mention this because you may see these terms used, and they do have strict definitions behind them. So-called paroxysmal atrial fibrillation is AFib that is intermittent and generally terminates without intervention within 7 days of onset. Persistent is that which requires an intervention and persists greater than 7 days. Long-term persistent is that is continuous, lasting more than 12 months. And permanent atrial fibrillation, sometimes referred to as chronic atrial fibrillation, is essentially that condition where a shared decision-making, you as the clinician, they as the patient, enter into a decision that you're not going to make further attempts to try and maintain sinus rhythm in that patient. So the prevalence of atrial fibrillation, this is data that was published in 2020 in JACC, looking at the projected prevalence of atrial fibrillation. We have an aging population with roughly 10,000 baby boomers turning 65 every day. And not surprisingly, given the fact that age is a major driver of not only risk-related atrial fibrillation, but atrial fibrillation itself, as we have an aging population, it's not surprising that the expected prevalence of atrial fibrillation, just in this case out to 2030, is expected to grow appreciably. In general, the risk of atrial fibrillation increases appreciably once you enter your 7th decade of life. We have all met people who have atrial fibrillation in their 60s, 50s, and even 40s, 30s, and 20s. But majority of individuals develop atrial fibrillation in their 7th decade of life, and this is showing different population listed here by the colors: white males or men, white women, African American men, and African American women. This is obviously bringing up two sexes and two racial groups, but there are other publications that have broken this down into much larger groups, either by race or ethnicity. There is heterogeneity amongst the population, whether we're talking about men versus women or different races, but appreciably almost across the board, the 7th decade is the inflection point for most of these individuals having a higher likelihood of developing atrial fibrillation. When we talk about clinical presentation of atrial fibrillation, not surprising to maybe many of you, it's important to know, I'm going to go back one here. It's important to know that there are a number of risk factors that predispose to the development of atrial fibrillation. And these are broken out in this recent publication in JACC in 2020 into those on the left-hand side that represent non-reversible risk factors. Really hard to modify something that's not reversible, but there is an increasingly larger percentage of risk factors that are actually reversible or can be addressed. And there's a lot of overlap with a growing prevalence of cardiometabolic disease and susceptibility to not only atrial fibrillation, but risk for heart failure, risk for ischemic heart disease. And so there's a marked confluence with these risk factors that are shared across many different cardiovascular conditions. I'm going to come back to this, but the most recent guidelines have really made it a priority of reinforcing, as was shared in two of our speakers thus far, the importance of upstream prevention in preventing the genesis of these risk factors, which ultimately will reduce the prevalence of atrial fibrillation and the risks associated with it as a result. The questions often come up is, what is the relative magnitude of those risk factors in terms of the development of atrial fibrillation? This is from the UK Biobank study. If you're not familiar, it's an amazing, it can prove challenging to sort of make sense of some of the data that comes out, but it's an amazing repository out of the United Kingdom. It's an observational cohort analysis where they're collecting survey data, sociodemographic data, and then biomarker data, laboratory data, imaging data to be able to look at this population. In this case, over 5 million person years of individuals, observational cohort of just under 24,000 individuals that developed atrial fibrillation, essentially asking the question, what was the population attributable risk of drivers of the development of atrial fibrillation? And as we will increasingly hear more about in years to come, the importance of cardiometabolic disease or risk factors being a driver of risk and controlling those cardiometabolic risk factors being key. So although we talk about a lot of different things, even including potential genetic predisposition, cardiometabolic risk factors overwhelm the likelihood of developing atrial fibrillation in terms of the different risk factors that exist. So what should you do when you're evaluating a patient with atrial fibrillation? Well, it starts with a history and a physical examination. It is important to realize that many patients, particularly as they age, may have few or no symptoms with atrial fibrillation, thus the challenge of finding not necessarily the proverbial needle in the haystack, but how do you identify something that someone may not even recognize that they have? There are a wide range of symptoms, and we focus in on palpitations and tachycardia and fluttering, but generalized fatigue or weakness, decreased exercise tolerance or stamina, and then it can be a mimicker of ischemic heart disease or heart failure with symptoms of chest discomfort or shortness of breath. The signs are evident when someone's in atrial fibrillation, more challenging when they're not in atrial fibrillation. But just to highlight the value of a physical exam above and beyond identifying somebody in atrial fibrillation that you're seeing in the office or the hospital today is also potentially to identify other potential contributors to the genesis of that atrial fibrillation, namely valvular heart disease, concomitant heart failure, etc. So this is a really important, and I'm going to take just a couple of moments to highlight this because the concept of screening for atrial fibrillation is a logical one when you begin to think about it. And I want to just define screening because many of us are familiar with the concept of mammography, screening test, but there's different types of screening that exists overall. So opportunistic screening as defined in the literature is you are seeing a patient in clinic today and they are complaining of a rash on their legs. But as part of the evaluation, you do pulse palpation, you're palpating their radial pulse, and you said, that's odd, you have an irregular rhythm, I haven't noticed that before. You're screening them opportunistically when they're coming in for a different reason overall. Or in the process of listening to their heart and their lungs, you're doing their physical exam and you notice that they have an irregular rhythm. Systematic screening is this concept of what we refer to often as mass screening. Should we be having analogous to colonoscopies for screening purposes, mammograms for screening purposes, looking for a condition overall? Now, does it make sense? When you think about colonoscopy looking for colon cancer, mammography looking for breast cancer, we have relatively prevalent conditions that if identified early enough, something could be done to intervene because the consequences of having unrecognized, untreated breast cancer and colon cancer can be devastating and life-threatening. Well, when we think about atrial fibrillation, a prevalent condition, risks associated with it are those that I listed before, stroke and a number of other adverse events, and we have therapies that can mitigate that risk. So it becomes very logical as we talk through this to say, is there a role for mass or systematic screening in this patient population overall? And then to throw a complete wild card in the mix, we have devices that people have bought to be able to order food off of their watch, or they want to track their fitness. And these devices say, with the alerts that can be turned on, you may actually have atrial fibrillation. So the technological advances in consumerism have advanced the field at a pace that we don't know exactly what to do with the information right now. So as it relates to this overall, I would make a strong argument that what I'm going to share with you on the next slide about guidelines as of today as it relates to screening is really about the concept of systematic screening. Should we be systematically looking at a population, let's say over the age of 75 years, all individuals, or those over the age of 65 that have additional multiple risk factors? There's guidance that's been issued I'll get to in 1 second. But I would not at all in any way dissuade you from doing opportunistic screening, where if you're in the midst of evaluating a patient for something completely unrelated, they have an irregular rhythm, you listen to their heart, it seems irregular, getting an electrocardiogram, going down that path is appropriate. So what do our guidelines say? The U.S. Preventive Services Task Force issued this just about 18 months ago and currently gives a grade I statement. There's insufficient data as of today from the U.S. Preventive Services Task Force to make the argument to systematically do mass screening for individuals to look for atrial fibrillation. That all being said, we do not have guidance right now about what to do with someone who chooses to purchase a watch or another device that will trigger that, and we will continue to see new evidence and guidance that comes out from groups like the American College of Cardiology and the American Heart Association. We as clinicians and clinical team members may say, I didn't tell them to buy the watch, they chose to do this on their own, and subsequent to that, we need to figure out how best to move forward with evaluating them thereafter. So in the circumstance where you have a patient you've diagnosed with atrial fibrillation, what is the initial evaluation? In this case, an electrocardiogram, if you have not otherwise done one, is of key importance overall. It not only confirms the diagnosis that you may suspect, but also may give insights about other abnormalities involving their heart, presence of Q waves, ST or T wave abnormalities that may be indicative of ischemic heart disease, presence of left ventricular hypertrophy or left atrial enlargement. Again, not necessarily on this the most sensitive or specific way to do that, but nonetheless it will provide additional insights. Our guidelines today talk about laboratory, cardiac, and other potential testing. These are listed up here, but basics including a complete blood count, a metabolic panel, an assessment of thyroid function, as clinical and subclinical hyperthyroidism accounts for a minority, but when you have that, recognition and treatment of that is key importance overall. And then targeted testing based upon other clinical conditions that you may suspect. In terms of cardiac testing, an echocardiogram to look at the structural morphology or function of the heart, and then multimodality imaging, additional ECG monitoring in the ambulatory setting may all be clinically appropriate. But you have to ask the question, what is the purpose of these additional tests? What am I looking for? And ultimately, I would say, how is that going to change my management or practice? And then the other testing that has been called out either as no net benefit whatsoever is evaluation for acute coronary syndrome pulmonary embolism should not be performed in the absence of other symptoms or signs that suggest that that in fact is a true and related, or more likely true and unrelated condition overall. So initial and long-term management, this is where I'm going to spend the bulk of the time today talking through things. This is a nice concept of the goals or pillars of care for atrial fibrillation that was called out. This is from the guidelines that just came out this year, really saying that there are three primary goals. I would argue one not more nor less important than the other as it relates to this. They really reinforced also the concept of access to all aspects of care for all, and this really is a call out of breaking down barriers of health equity and access to care that in fact we don't do well in cardiovascular medicine, and this includes to atrial fibrillation in terms of using guideline recommended interventions, evaluation and treatment based upon individuals that may be stratified by sex, race, age, ethnicity, and other social determinants of health. Beyond that, it's about stroke risk assessment, assessing their risk for thromboembolism, and then initiating treatment, optimizing them. This is modifying all modifiable risk factors, and then symptom management. How do I control their symptoms overall? And at the bottom, you can see the importance of shared decision-making and treating risk factors and enacting behavioral changes that really move up towards that central pillar. As many of you know, and the good news is it hasn't changed since the last guidelines, the CHADS-VASc score is the principal means that is recommended in the current US guidelines and European guidelines as a means for doing stroke and systemic thromboembolism risk assessment overall. The acronym corresponds to heart failure, hypertension, age, diabetes, prior vascular disease, prior thromboembolism, and then a sex category overall. It does call out, similar to our cholesterol guidelines, that there are other so-called risk enhancers. So the presence of these other risk factors on the right side may in fact identify an individual in whom their CHADS-VASc score becomes insufficient in adequately assessing their stroke risk. These groups have an even heightened risk for stroke or systemic thromboembolism above and beyond that may be conveyed simply by their CHADS-VASc score alone. How does the CHADS-VASc score perform? We're largely dividing individuals into groups who have a CHADS-VASc score of 0, or for women, a CHADS-VASc score of 1, but the only one you get is as a result of being a woman. And the risk of those individuals on an annualized basis is extremely low. And I'll come back to how our treatment reflects that in a second. The high-risk group are men with a CHADS-VASc score of 2 or greater and women with a CHADS-VASc score of 3 or greater with that additional point simply because one is a woman. And the risk goes up appreciably beyond that, so as your score goes up to the right on the right side, your risk on an annualized basis of stroke or systemic embolism goes up as well. And then there's this intermediate risk group that has a CHADS-VASc score of 1 as a man or 2 as a woman, and they're at an intermediate risk overall. So I love this paper that was put out by Ben Steinberg before he left Duke, and it comes from the Orbit AF registry. And it really reinforces, while risk scores are nice and they help us, is there true value for this? And I'm not showing the bleeding data, but I'll mention it in a second. And essentially, looking at 10,000 patients with atrial fibrillation and asking clinicians to assess, this is with the CHADS-2 score, but I would argue that it's applicable with the CHADS-VASc score, Assess what you believe that patient's stroke risk is based upon whatever means you use, not formally using a risk score, and then calculate their risk again using a risk score. And the bottom line is, as clinical team members, as clinicians, we tend to underestimate the risk of stroke or systemic embolism in the population without the help of a risk score. And in the case of bleeding, we do the opposite. We overestimate the projected risk of bleeding in that population. Two things setting people up for the potential of undertreatment with therapies to mitigate the risk of stroke or systemic embolism overall. So this is my call out to say, even if the math is easy to do in one's head, go through the logic of actually just plugging those numbers in quickly, arriving at a score. The good news is that the treatment thresholds for initiation of antithrombotic therapy are relatively straightforward. I do want to call out the importance of bleeding risk assessment, and there are multiple bleeding risk scores. This shows has bled, it shows Atrial on the right, hemorrhages, and there are others beyond even these two, and the hemorrhages bleeding risk score. The principal goal of bleeding risk scores, as called out in the guideline, is to identify potentially modifiable risk factors that can be remedied as a means of reducing bleeding risk. There's no rule that says if your bleeding risk score is higher than your CHA2DS2-VASc score, you don't use anticoagulant therapy. Rather, can I identify, does this invite a discipline of inventorying what are those risk factors that I should be looking at, and if in fact people are using lots of non-steroidal anti-inflammatory agents, if people are drinking increased amounts of alcohol. If in the case of somebody on a vitamin K antagonist, they have a labile INR, what can I be doing to tighten things up to mitigate bleeding risk? So what do our updated guidelines 3.5 months ago tell us that we should be doing from an antithrombotic therapy overall? Number one, overall, if you have a CHA2DS2-VASc score of 2 or more as a man, 3 or more as a woman, your annualized risk of stroke exceeds or is equal to 2% per year, anticoagulation is recommended. And if in fact you have a CHA2DS2-VASc score of 1 as a man or 2 as a woman, and that was a class 1 recommendation in green, it drops to a class 2A recommendation, but the guidelines give now a stronger preference than they ever had for those that have a score of 1 or more as a man and 2 or more as a woman to also say anticoagulation is a reasonable approach in this patient population overall. On the far right, they say direct oral anticoagulants should be given preference to over vitamin K antagonists like warfarin in all circumstances unless they have moderate or severe mitral stenosis or a mechanical heart valve. So this includes people that have had a mitral valve repair, have a bioprosthetic aortic valve. These individuals are all eligible and should be given preference to a direct oral anticoagulant over a vitamin K antagonist where possible. Exceptions, moderate or greater degrees of mitral stenosis or a mechanical heart valve. Aspirin, either alone or with clopidogrel, not recommended to reduce stroke risk. And if you have no risk factors, meaning a CHA2DS2-VASc score of 0 as a man or 1 as a woman, where the only risk factor is because of being a woman, they recommend that aspirin to prevent thromboembolic events is not recommended, no benefit. So we've largely gotten in this world that if your CHA2DS2-VASc score is 0 as a man, 1 as a woman, you use no antithrombotic therapy, and to a large degree, if your score is above that, 1 or greater as a man, 2 or greater as a woman, anticoagulation is either outright recommended or it is reasonable based upon what your score is. This is a busy slide. There's no way you're going to be able to see this. Maybe some of you have amazing eyes and you'll pick that little teeny needle out of the haystack, but on the left-hand side, there's a really nice illustration there highlighting the importance of monitoring for the potential of bleeding for those on a direct oral anticoagulant. Some people are set it and forget it, but the importance of assessment of liver function, renal function, and their blood counts to be able to see if in fact they're experiencing any subclinical bleeding events or are otherwise predisposed where something more must be done based upon the severity of liver disease, renal dysfunction, and what your bleeding risk may be. You, under those circumstances, should have different frequencies of monitoring these laboratory indices. And on the right-hand side is more what we've seen for many, many years in terms of the importance of routine monitoring of their INR to minimize outliers high and low. So You might say, is there another or different way? This is what our guidelines tell us about left atrial appendage occlusion or closure. For those less familiar, this is the vestigial outpouching of the left atrium. This was thought to be the appendix of the heart. It had no real purpose except to collect clots, and it accounts for about 90% of the strokes associated with atrial fibrillation. The clots originate there, so it makes sense if you can exclude that appendage from the systemic circulation, mitigate the risk of stroke. And it was beyond the time allotted today to go through the evidence to support it, but it's a class 2A recommendation in those that are at increased stroke risk, and I would say Chad's VAS score of 2 or greater as a man, 3 or greater as a woman, and a contraindication of long-term anticoagulation to consider as an option percutaneous left atrial appendage closure. It's reasonable. And a 2B in people who do not have a contraindication to anticoagulation, but those based on patient preference, the strength is less strong as reflected on the page here. So as we move through beyond stroke risk assessment and management, we move into modifiable risk factors. This is back to that same article that came out in JACC in 2020 that I referenced. This is the basic building blocks of what was just discussed in the last lecture, but this is the keys to what we should be doing in this patient population. Weight management through diet and exercise, treatment of hyperlipidemia, treatment, and I would argue evaluation for and treatment of sleep apnea, very important. And I'll just fast forward, talk about symptom management. It's really hard to maintain sinus rhythm in those individuals that have moderate or greater degrees of sleep apnea that is uncontrolled. Hypertension control, diabetes management, it really reinforces that these are not just independent risk factors for the risk of stroke, but in and of itself, many of these conditions perpetuate the likelihood of having recurrences of atrial fibrillation, which can be associated with difficulty in managing their symptoms. And the last piece that I want to focus in on is symptom management for this patient population. And I'm going to pause to highlight this slide, which I really much like. And these are from 2 publications just in the last 2 years in JACC. And the argument is the concept of, do I control your heart rate alone without a so-called rhythm control strategy where the goal is to try and restore you back to sinus rhythm and do what I can with drugs or devices or procedures to maintain sinus rhythm? What should be done? And the agreement across the board is we should be talking about this with our patients and arriving at a plan overall. But there is an adage, and there are a lot of adages in cardiology, but one that gets talked about perhaps not as often as it should is AFib begets AFib. The more atrial fibrillation you have, it is not just a nuisance, it is not just a symptom, but it promotes adverse remodeling of the heart, left atrial enlargement, fibrosis, scarring, inflammation is a driver of this. All of that will cause unfavorable remodeling that perpetuates more episodes of atrial fibrillation. So in somebody that doesn't have an enlarged left atrium, doesn't have fibrosis, doesn't have scar formation, in those situations with normal left atrial function, atrial fibrillation tends to be very trigger dependent. There's a focus, there's an inciting trigger, and if I can prevent that trigger from driving that focus to evolve into atrial fibrillation, all is good. And this, in fact, is what, to a large degree, rhythm control therapy does. It is using drugs or procedures in the operating room, in the cath or EP lab, or a combo hybrid procedure by which to ablate and eradicate the focus or the trigger for atrial fibrillation. In contrast, the more atrial fibrillation you have, the more remodeling you have, the more substrate dependent you become. So under those circumstances, it becomes increasingly more difficult. And if you talk to any electrophysiologist, they will share this with you. The greatest success from atrial fibrillation ablation are people who have infrequent episodes of paroxysmal atrial fibrillation with small left atria who have not remodeled it. They have not gone far enough down the AFib begets AFib. So the argument to intervene earlier makes sense if, in fact, someone's trigger dependent. The further along they are in their disease state, the more challenging you are to maintain sinus rhythm with a rhythm control strategy. So when we talk about a rate control strategy, as probably many of you know, the atria can go at 400 to 500 beats per minute. Thank God we have something called an AV node that actually slows that and prevents all of those impulses in getting down to our ventricles, because essentially we would be fibrillating in our ventricles and would not be alive. So under these circumstances, we use rate controlling agents to potentiate or augment the effects of the AV node to slow their heart rate. So what are the two primary reasons to prevent prolonged rapid ventricular rates? A, avoid symptoms, make people feel better, and or hemodynamic instability. And the more challenging thing, we've probably all seen individuals who are 80 years of age, they had no idea they were in atrial fibrillation, they present to you, they're going 145 beats a minute, they're asymptomatic, they've been in this not just for days, but weeks, if not longer, and their heart begins to say, I'm unhappy with you, no thank you, I'm gonna begin to poop out. They can develop a so-called tachycardia-induced cardiomyopathy. The good news is that this is one of those conditions that if you can get their rate and ideally their rhythm under control, the heart will often remodel favorably back to normal. We don't know the optimal heart rate with regard to atrial fibrillation. We use AV nodal blocking agents. They can achieve a heart rate less than 80 beats per minute, about 75%, and a heart rate less than 110 beats per minute, about 90%. But consideration should be given to a resting heart rate goal of less than 85 if they're symptomatic. And then based upon other trials that have been done in the past, it's about less than 100, 110 beats per minute in asymptomatic patients who are in atrial fibrillation, that's at rest, in the absence of having left ventricular systolic dysfunction. What are the medications we should be using for rate control? They're listed here, but it's largely beta blockers or so-called non-dihydropyridine calcium channel blockers, drugs like verapamil and diltiazem, as need be adding on drugs like digoxin in this circumstance. Avoidance, importantly, of calcium channel blockers in those individuals that have left ventricular systolic dysfunction with a left ventricular ejection fraction less than or equal to 40%. With regard to the rhythm control, as I shared before, this can be done in the cath lab, EP lab, in the operating room, or it can be done with a hybrid procedure. The principal goal, often on top of rate control, is to be able to improve symptoms, improve quality of life. And neither approach has been conclusively been shown to improve survival relative to one another. Regardless of the strategy that you use, and I do want this to be one of the key takeaways, by undergoing an ablation, by being on antiarrhythmic drug therapy, even in the person who says, I have no symptoms, I feel great, that does not eliminate your thromboembolic risk, in part because for every symptomatic episode of atrial fibrillation, you may still have asymptomatic episodes. So the guidelines are emphatic about saying, don't make choices, do not stop anticoagulation because somebody had an ablation. Just calling out atrial flutter, particularly typical atrial flutter, is perhaps one exception. So if you said, I have an electrophysiologist, I swear that they stopped the anticoagulation. There are selected cases for a relative of AFib, atrial flutter, but for AFib itself, not the case. And then for patients managed with a rhythm control strategy, a rate control strategy is often utilized as a complement to that overall. I think this is very nice, it's very busy, it's 2 slides here, but just to say there are some factors when you're deciding, do I rate control somebody? Do I rhythm control strategy or embrace that strategy or that approach? It's informed to a large degree based upon some of these factors overall. Some of these in this case are patient factors overall that may inform that decision. Some of these, in addition to that, are additional factors that are above and beyond the unique patient, get into the issues about how their heart functions, what their left atrial size looks like, do they have concomitant valvular heart disease overall. Last few slides, I just want to highlight emergency department evaluation because the question is, somebody's sitting in my clinic, they're asymptomatic, but their heart rate's 130 beats per minute. Do I need to send them to the emergency department? In short, most patients, new onset established AFib, can be evaluated in the outpatient setting. Inadequately controlled symptoms, usually in the setting of a rapid ventricular rate, are the primary reasons why most people seek medical attention in the emergency department, and where appropriate, if you use a rate control strategy, even initiated by somebody you're meeting for the first time in the clinic, you can help address that. No question, in my opinion, hemodynamic instability is the primary reason you send somebody to the emergency department for further evaluation and treatment overall. Obviously, in the absence of shock, but somebody having decompensated heart failure and other serious comorbidities, ongoing angina, they're having essentially a stress test by sitting at rest because they're at a heart rate of 140 beats per minute in AFib. That may be telling you if they're having chest pain, something more needs to be done in that situation. In the emergency department, for those of you who work there or in the acute care setting, acute rate control, you can see if they're hemodynamically unstable. Cardioverting these individuals is of key importance. And then there are a range of either rate lowering or antiarrhythmic drugs that may be considered with varying degrees of recommendation in the guidelines for those that require an addressing of a rate control strategy in this population, informed by whether or not they have decompensated heart failure. And lastly, referral to cardiology. Who should see a cardiologist? This actually came out from the British. It was in the British Journal of Cardiology more than a decade ago, but I actually like this a lot, and it's just sort of a mental checklist of 10 steps to go through before you send the patient to cardiology. There are no rules about this, at least in my community, but I think making the diagnosis, establishing the duration or the type of AFib, assessing how symptomatic they are, figuring out a cause if you can figure it out, inquiring about those comorbidities, examining the patient, doing an ECG, basic laboratory testing, and an echo, getting them on rate control agents, regardless of whether a rhythm control strategy will be pursued, starting the patient on anticoagulation, presuming they're a candidate, and then asking the question, what am I sending them to the cardiologist for overall? So in conclusion, I would say this is a nice, again, takeaway from that nice review article in 2020 in JACC. It's about stroke management, assessment of rate versus rhythm control strategy. It's about, on the right-hand side, modifying the modifiable risk factor, whether in primary or secondary prevention, increasing disease awareness, and then ensuring that all individuals, regardless of who they are, where they live, have access to care and can derive the benefits that you all give them in this regard. So with that, I will open up for questions. Thanks so much.